So from today onwards, we are moving on to our infectious diseases part. We'll be focusing on our infectious diseases. Till this many days, we were discussing about the basics of microbiology and the basics of antibiotics. So from today onwards, we'll be dealing more with the infectious diseases, the different infectious syndromes. So we expect you to be interactive from today onwards. Keep your chat box open because I'll be asking questions in between. Now it's your time to apply all those things into clinical practice. So that is how you learn. Okay, so let me start. So today we'll be dealing with the respiratory tract infections. Mostly I'll be dealing with the upper respiratory tract infections and ENT infections. Along with that, I'll be also covering community-acquired pneumonia. So as you know, the upper respiratory tract is the part from the nasal cavity to the larynx. So all those infections such as the common cold, pharyngitis, tonsillitis, epiglottitis, sinusitis, laryngitis, and otitis media, which is an ENT infection. All these things I'll be covering today. Along with that, I'll be also covering community-acquired pneumonia. So before moving on to the class, I'd like to ask you all, so if a patient is presenting with symptoms of common cold, such as running nose or otherwise the rhinorrhea, sore throat, and sore throat, running nose, and these kind of symptoms, what antimicrobial treatment or what treatment will you offer for this patient? So just type in the chat box. So sore throat, fever, running nose, cough, low grade, like low grade fever, not high grade, headache, please type in the chat box fast. Make it short, okay. Depends on number of days. Consider it as like a short term. Yeah. So if it is viral, what can be the treatment? Should we give any treatment? Should we give any antiviral therapy? Make it fast. Whatever you think in your mind, just give it. Okay, initially it can be viral and antibiotics are not needed. For fever, acetaminophen, ibuprofen, of course, okay. Antihistamine can be given. Amoxicillin, paradiethyl carbamazepine, okay. Next. Okay. Okay, so I can see multiple answers here. Some are saying that symptomatic treatment is enough. Some have mentioned name of some of the antibiotics such as Aci or Doxy, Amoxiclav. Okay, let us see. So my slides are moving, right? So common cold. It is characterized by nasal congestion, rhinorrhea, sneezing, sore throat, cough, low-grade fever, headache, and malaise. That is excessive tiredness. So it is commonly, as you know, it is of viral etiology, and the common causes, the most common viruses included are the rhinovirus and coronavirus. It is not the coronavirus is not the COVID SARS-CoV-2 virus which causes COVID-19 infection. It is the mild, it is the simple coronavirus that can cause common cold. Then it is usually self-limiting and symptomatic therapy is required. That means excess fluids and rest are all those things which you can suggest. No antibiotic treatment required for common cold. So this is one of the important perspective of your antimicrobial stewardship program. you need not prescribe antibiotics for common, like when a patient presents with symptoms of common cold. Keep in mind that. Yes, symptomatic treatment, of course, it includes like the ipratropium bromide, which you give for running nose, and the antihistamines. Usually, antihistamines alone is not sufficient. Antihistamine combination, like antihistamine decongestant combinations are recommended. You can go through the guidelines. I'm not going into detail of all those things. Okay. Acetaminophen NSAIDs can be given for pain management. The next is pharyngotonsillitis, that is the throat infection or the infection of the tonsils. It is usually caused by, one second, yeah. It is usually caused by what is gases? Is the short form for, is a bacteria. Group A streptococcus. So this pharyngotonsillitis is usually caused by group A streptococcus. For this condition, you need antibiotic treatment. The usual treatment is amoxicillin 500 mg TID for 10 days. That is the recommended treatment. Alternatively, you can give penicillin B, cefalexin, or azithromycin. The most recommended and preferred one is the amoxicillin 500 mg TID for 100 days. Sorry, 10 days. I'm sorry. That is the next. Next is the retropharyngeal abscess or other deep neck space infections. So here in this etiology will be viridans group of streptococci. Which are the viridans group of streptococci? Can someone type? No, all of you just type in the chat box. Viridans group of streptococci. Do you remember? Okay, fine. It is strep, mutans, strep, mitis, etc. Streptococcus anginosus is also a viridans group of streptococci. So streptococcus and anginosus is the most common cause of retropharyngeal abscess, and it can also be caused by other oral anaerobes. So your oral cavity, the anaerobes are present in large amount in the oral cavity. So this can be an etiology for many of the infections associated with it. Severe, when a patient has severe neck or throat pain and swelling with fever, difficult swallowing, it can be due to retropharyngeal abscess or other deep neck space infections also you have to suspect. And as of course you need, this is a severe condition, you need antibiotic treatment for this. Sometimes you also need surgical interventions in the form of drainage and all. So if the infection, if you're suspecting an oral or odontogenic source, odontogenic means a dental source or from the teeth, then you have to give ceftriaxone 2 gram IV OD that will cover all your streptococcus with injection metronidazole, which is given for anaerobic coverage. Or otherwise, you can give amoxicillin clavulanic acid, which has got coverage against both. That is, it will cover anaerobes as well as it will cover streptococcus. Okay, so that is the treatment for this. Next is autogenic source. Autogenic means the source is ear. So ear infection, one of the most common cause of ear infection will be Pseudomonas aeruginosa. So in this case, you'll have to cover for Pseudomonas anaerobic coverage. You'll have to give anaerobic coverage. So here the option will be cefepime 2 gram TDS, metronidazole 500 mg TDS. Otherwise, you can give piperazillin tazobactam. What is the advantage of piperazillin tazobactam? It covers both Pseudomonas and anaerobic. It has also got anaerobic coverage. Along with that, it will also cover several gram-negative organisms. Next is meropenem. Again, it has got a broader coverage. It will cover your Pseudomonas, anaerobic organisms, and it has got wide gram-negative coverage. Okay, next is the cyanogenic source. That means the source is from the sinus. Then you will have to cover for strep pneumonia and staph aureus. For staph aureus is a gram-positive organism. So you can give vancomycin with ceftriaxone for streptococcus pneumoniae and metronidazole for anaerobic coverage. Is that clear? Any doubts till this? Because you need to know about the antibiotics which you have to give for Pseudomonas. For anaerobic coverage, what are the antibiotics you can prescribe? And yeah, and for gram-negative infections like streptococcus pneumonia, what is the treatment of choice? That all you should like capture it from here. Okay, so I hope it is clear for you. Do you want any more clarification till now? Okay. Next is the epiglottitis, that is the infection or the infection and inflammation of the epiglottis. The usual causes, it can be caused by Haemophilus influenzae, Streptococcus pneumoniae, Group A Streptococcus. Group A Streptococcus is the Streptococcus pyogenes. I forgot to tell you before. It is the Streptococcus pyogenes, which usually causes cellulitis, necrotizing fasciitis, soft tissue infections, and all. So that is an etiology. The next is the Staphylococcus aureus. So here, epiglottitis is again a severe condition where you need airway management because the patient will have difficulty in swallowing, and intubation may be required in these kind of patients. Antibiotic treatment, it should focus on both gram negative as well as gram positive. So to cover the gram negative, ceftriaxone 2 gram OD can be given. It will also cover the streptococcus, which is a gram positive one. Then for MRSA or other staph aureus infections, you can give vancomycin. So ceftriaxone 2 gram OD plus vancomycin, or otherwise another third generation cephalosporin, that is the cefotaxime 2 gram TDS with vancomycin can be given. So can you tell, looking at this regimen, can you tell what is the difference between ceftriaxone, or what is the advantage of ceftriaxone over cefotaxime? Just look at the regimen, you can understand. You'll get it just looking at the dosing.
Once daily dose is only required.
Ceftriaxone has got long T-half, so once daily dosing is required. Cefotaxime, even though it has got almost similar coverage as that of ceftriaxone, the disadvantage is that you need to dose it 3 times due to its short T-half. Okay. Next is the acute rhinosinusitis.